Welcome to the Deep Dive. We're the show that cuts through all the noise to bring you the essential knowledge and maybe some surprising truth you need to be genuinely well informed. Today, we're tackling small cell lung cancer, SCLC. It's a really aggressive type of cancer, technically a high-grade neuroendocrine carcinoma.
Which basically means it starts in hormone-producing cells, neuroendocrine cells, and grows very, very quickly.
Exactly. And its impact is huge. It was actually the leading cause of cancer deaths in the U.S. in 2024. Second most commonly diagnosed lung cancer overall. Now, the numbers have dropped a bit, thankfully, from about 6.6 cases per 100,000 down to 4.7 in 2021.
Which corresponds pretty closely to people smoking less tobacco.
Right. But it's still a major challenge. So our mission today, we're going to unpack a big comprehensive review on SCLC. It's an article by Doctors Kim, Park, and Chiang, just published in JAMA in 2025.
Yeah, and we want to pull out the key insights, give you the context, maybe highlight some of those facts that make you go, huh, I didn't know that. Our goal really is to give you a clear picture. What is SCLC? How does it usually show up? And crucially, what's new in diagnosis and treatment? Because things are changing fast.
They really are. And speaking of surprising facts, get this. Something like 60% of patients with SCLC, they have no symptoms when they're diagnosed.
60%. It's hard to wrap your head around.
It is. And yet at the same time, there's this incredibly strong link to smoking. Like 95% of patients have used tobacco. We'll also get into a really critical difference, the staging. Limited stage versus extensive stage. It completely changes the treatment plan.
Okay, so let's dive in. The driving force behind this. It's overwhelmingly cigarette smoking, right? That 95% figure is just massive.
It absolutely is. It highlights the, devastating impact of tobacco.
Okay.
But here's a nuance that's important.
Yeah.
Even if someone quits smoking, the risk does go down, but it stays elevated for like over 30 years. Wow, 30 years. So it has a very long tail.
A very long tail. But then there's this other side, almost a counter-narrative in the data. Somewhere between, say, 2.5% and maybe 13% of SCLC cases. They happen in people who've never smoked.
Never smoked at all.
Never smoked.
Yeah.
And here's the kicker. These patients might actually have a better prognosis. One study found their survival was around 18 months compared to about 13 months for smokers.
Huh. 5 months longer. That's significant. What does that tell us? Does it suggest maybe it's a slightly different disease in never smokers?
That's exactly what researchers are thinking. It's a huge clue. It suggests SCLC isn't just one single thing. Maybe the biology is different, fewer tobacco-driven mutations. And that could potentially open up avenues for different kinds of treatments down the line, especially for that group. It's definitely an active area of research.
Interesting. Okay, so broader picture numbers. How many people are we talking about?
So roughly 16,000 new cases each year in the U.S., based on 2024 estimates. The median age when diagnosed is 69, and it's slightly more common in men, about 5.1 cases per 100,000 versus 4.6 for women.
And are there differences across different racial or ethnic groups?
Yes, there are disparities. The incidence rates are highest among non-Hispanic, American Indian, and Alaska Native individuals. Around 8.5 cases per 100,000 there.
Right. Okay, so we mentioned that startling 60% asymptomatic figure. But when people do have symptoms, what are they typically experiencing?
Well, the common respiratory ones are things like a cough that just won't quit. That's about 40% of patients. Shortness of breath, maybe 34%. And then coughing up blood, hemoptysis, that's around 10%.
Okay.
But yeah, that high asymptomatic rate, it just makes early detection so difficult. Often by the time it's found, it's pretty advanced.
That really paints a picture of the challenge. What if the cancer is already spread? What kind of symptoms might show up then?
Right, metastases. So for example, about 15% of patients already have spread to the brain at diagnosis. That might cause headaches or maybe weakness in one part of the body. And then there are what we call constitutional symptoms. These are more general things like losing weight without trying, loss of appetite, just feeling really fatigued all the time.
Yeah.
These often signal that the disease is more widespread.
Now, here's where it gets really interesting, I think. SCLC can cause these things called paraneoplastic syndromes. Can you break that down? What are they?
Yeah, this is a fascinating and really distinctive feature of SCLC. Basically, the tumor itself starts producing hormone-like substances, or it triggers the immune system to attack healthy tissues by mistake.
Wow.
So you get symptoms in parts of the body nowhere near the actual tumor. A classic one is superior vena cava syndrome, SVC. Affects maybe 10% of patients.
SVC, what does that look like?
The tumor presses on the big vein returning blood from the upper body to the heart, the superior vena cava. So you get swelling in the face or neck, headaches, maybe swollen arms, even voice changes. Another common one is SIADH syndrome of inappropriate antidiuretic hormone secretion, seen in almost a quarter of patients, maybe 24%.
And what does SIADH do?
The body holds on to too much water, which dilutes the sodium in your blood. That's called hyponatremia.
Yeah.
And low sodium can really mess with brain function, confusion, seizures, in severe cases, even coma.
So these aren't just minor side effects. They can be really serious systemic problems. Are there others?
Definitely. There's Cushing syndrome. In maybe 2–6% of patients, the tumor makes cortisol-like hormones.
Ah.
That can cause fluid retention, edema, muscle weakness, high blood pressure, maybe low potassium levels, which is bad for the heart.
Yeah.
And then there's Lambert-Eaton myasthenic syndrome, LEMS. That's about 2–3%.
LEMS. What does that involve?
It's an autoimmune attack on the nerve-muscle connection. So you get muscle weakness, trouble with coordination, ataxia, and reduced reflexes. Recognizing these syndromes is key because sometimes they're the very first sign something's wrong.
Okay, so whether it's symptoms or these paraneoplastic syndromes or maybe just an incidental finding on a scan, how do doctors confirm it's SCLC? What's the diagnostic process?
It usually starts with imaging, like a chest CT scan. Often you'll see a mass near the center of the chest or maybe enlarged lymph nodes there. That's pretty common, like 85% see a central mass, 75% enlarged nodes.
But you need more than a scan, right?
Oh, absolutely. The definitive diagnosis always comes from a biopsy. Taking a small tissue sample, either from the lung mass itself or maybe an enlarged lymph node, or even a spot where it might have spread.
And under the microscope, what are pathologists looking for? What makes it SCLC?
They're looking for these characteristic cells, often described as small, round, blue cells. They're tiny, packed really close together with a huge nucleus compared to the rest of the cell.
Okay.
And crucially, they have a very high mitotic rate. That just means they're dividing super fast. It's a big reason why SCLC is so aggressive. Then they use special stains immunohistochemistry to look for specific protein markers. Things like TTF1, which is positive in about 80%, and CD56, which is almost always there, like 90–100% of the time.
Gotcha. And what about the genetics, the molecular side?
Yeah, that's really important too. Almost universally, SCLC cells have lost function in two key tumor suppressor genes, RB1 and TP53.
The brakes on cell growth.
Exactly. In SCLC, those brakes are basically gone. We also know now there are different molecular subtypes. They call them A, N, P, and I, based on which genes are active. Understanding these subtypes might become really important for tailoring treatment in the future.
Now, you often hear about PD-L1 testing in other lung cancers. How does that work in SCLC? Is it useful?
That's a key difference. PD-L1 is a protein cancers can use to hide from the immune system. In non-small cell lung cancer, the level of PD-L1 often helps predict who will benefit from immunotherapy, those checkpoint inhibitors.
Right.
But in SCLC, it's much more variable. PD-L1 levels can be anywhere from 0% to 80%. And critically, the level doesn't reliably predict response to immunotherapy. So we don't use it for treatment decisions in SCLC like we might in non-SCLC.
Okay, that's important. I also came across something about non-SCLC sometimes transforming into SCLC. Is that common?
It's not common, no, it's rare. But it's a very serious situation when it does happen. It's seen more often in non-SCLC patients who have certain mutations, like EGFR or AOK, especially if they also have changes in those RB1 or TP53 genes we mentioned.
And the outcome isn't good, I take it.
Unfortunately, no. When non-SCLC transforms into SCLC, the survival is typically shorter, maybe only 6 to 8.5 months, compared to around 13 months for SCLC that started as SCLC, what we call de novo SCLC. It's a real challenge because the treatments that worked for the original cancer usually stop working.
Right. Okay, so once the diagnosis is confirmed, the next step is staging. You mentioned limited versus extensive stage earlier. Why is this division so fundamental?
It's absolutely critical because it dictates the entire treatment approach and, importantly, the intent of the treatment. Is the goal cure or is it managing the disease? So limited stage SCLC, LS-SCLC, it's at 30% of patients. It means the cancer is confined to one side of the chest, one hemithorax, and crucially, it can all be included within a single tolerable radiation field.
Okay, contained enough for targeted radiation.
Yeah. Exactly. Extensive stage, ES-SCLC, that's the other 70%. That means the cancer has spread beyond one hemithorax. It could be in the other lung, distant organs like the liver or brain, or it's just too widespread within the chest to be targeted with a single radiation field.
And you determine this with imaging?
Yes. Accurate staging relies heavily on imaging CT scans of the chest and abdomen, a brain MRI because of the high risk of spread there, and often a PT-CT scan to look for spread elsewhere in the body. And that 70% figure for extensive stage It really underscores the challenge. Most patients already have widespread disease when they're first diagnosed.
Okay, let's unpack the treatment for limited stage then. You said the goal here can actually be curative, which is huge. What's the standard approach?
Right. For LS, SCLC, the standard of care is potentially curative therapy. It involves giving chemotherapy and radiation therapy together, concurrently. The chemo is usually a combination of a platinum drug, like cisplatin or carboplatin, plus etoposide, typically for 4 to 6 cycles. And this is given at the same time as high-dose radiation therapy to the chest. Initial response rates are actually quite good. The tumor shrinks in 70% to 90% of patients.
That sounds promising. Are there different ways to give the radiation? I think I read about once daily versus twice daily.
That's right. There are 2 main schedules. The traditional approach, often still considered first line, is giving radiation twice a day over a shorter period, about 3 weeks. The alternative is once daily radiation over a longer period, maybe 6.5 to 7 weeks.
Is one better than the other?
Studies show they have pretty similar outcomes in terms of cancer control and survival. The twice daily has the advantage of being a shorter overall treatment time, which is why it's often preferred.
Is surgery ever an option for limited stage?
For a very small select group, yes. Patients with very early stage disease, like stage I or IIA, where there's no lymph node involvement found before treatment, surgery, usually removing a lobe of the lung, followed by chemotherapy, might be considered. But that's definitely the minority.
Okay. Now, you mentioned something earlier that sounded like a real game changer. Consolidation immunotherapy for LS-SCLC. Tell us about that.
Yes, this has been a major leap forward. After patients complete the concurrent chemoradiation, if the cancer hasn't progressed, they now typically receive consolidation immunotherapy with a drug called durvalumab.
That's an anti-PD-L1 drug.
Exactly. It helps the immune system recognize and attack any remaining cancer cells. It's given for up to 2 years. And the impact has been dramatic.
How dramatic?
It significantly improved the median overall survival. It went from about 33 months without it up to nearly 56 months with consolidation durvalumab.
Wow, almost doubled. That's incredible.
It really is. The 3-year overall survival rate is now around 56.5%. It's fundamentally changed the outlook for LS-SCLC.
That's fantastic news. Now, another thing often discussed with limited stage is PCI, prophylactic cranial irradiation. Brain radiation. Why is that done?
Right, TCI. Well, SCLC has a nasty habit of spreading to the brain. Without preventative measures, something like 60% of patients might develop brain metastases within 3 years.
60%. That's incredibly high.
It is. So PCI is recommended for patients with LS-SCLC, specifically stages IIB to II, after their initial chemoradiation has shrunk the tumor. The idea is to zap any microscopic cancer cells that might already be in the brain but are too small to see on scans. And it works. It reduces the chance of brain metastases showing up later, and it improves 3-year overall survival slightly, from about 15% to nearly 21%.
But there's a downside, isn't there? A trade-off.
There is, and it's a significant one. PCI can cause long-term neurocognitive problems, issues with memory, concentration, executive function. This can affect up to 65% of patients who receive it.
Oof, that's a tough choice for patients.
It absolutely is.
Right.
It's a serious quality of life concern. There are ways to try and mitigate it, like using a drug called memantine during and after PCI, or using newer radiating techniques that try to spare the hippocampus, an area important for memory.
Or can patients skip PCI altogether?
Yes. For patients who are concerned about the cognitive risks or perhaps are older or have pre-existing issues, an alternative is close surveillance with regular brain MRIs. If metastases do show up later, they can often be treated effectively then, usually with focused radiation like SRS.
Okay, that makes sense. Let's shift gears now to extensive stage SCLC, ES-SCLC. That's the majority, 70% of patients. What's the goal of treatment here?
For extensive stage disease, unfortunately, the goal shifts from cure to palliation. The primary aims are to control the cancer, relieve symptoms, maintain or improve quality of life, and extend survival as long as possible.
And what does that first-line treatment look like?
The standard first-line approach now is combination therapy. Platinum etoposide chemotherapy, just like in limited stage, but given together with immunotherapy, usually an anti-PD-L1 agent like durvalumab or tislelizumab.
Chemo plus immunotherapy right from the start.
Yes. Patients typically get 4 cycles of the combination, followed by ongoing maintenance therapy with just the immunotherapy agent until the disease progresses or side effects become too much.
How well does this combination work initially?
It does lead to tumor shrinkage in a good number of patients, around 60–70%, but the durability is the challenge. The median overall survival is still only around 12 to 13 months.
Only a little over a year. despite adding immunotherapy.
That's right. It highlights just how aggressive ES-SCLC is. And a really stark statistic is that about 60% of patients will see their cancer start growing again within just 3 months of finishing the initial chemoimmunotherapy.
3 months. Wow, that's fast.
Incredibly fast. The 3-year survival rate for ES-SCLC is around 17–18%, and 5-year survival is only about 12%. So while we've made progress, there's still a huge unmet need.
Are there any other treatments used after that initial chemoimmunotherapy, like radiation?
Sometimes, yes. If a patient has disease remaining in the chest after the initial treatment, but nowhere else, giving consolidative radiation therapy to the chest might be considered. It's thought to potentially help control the disease locally for longer.
Okay. Given these relapse rates, especially in extensive stage, navigating relapse must be a huge part of managing SCLC. What happens when the cancer comes back?
It is, unfortunately, a very common scenario. As we said, about half of SCLC patients relapse after maybe 9 months. For ES-SCLC, it's often much sooner, maybe 4 or 5 months after starting maintenance immunotherapy. And once the cancer progresses, if no further treatment is given, survival is typically very short, maybe only 3 to 4 months. It's driven by the cancer evolving, developing resistance.
So what are the options then?
The first and strongest recommendation for any patient with relapsed SCLC is to enroll in a clinical trial, if possible. That's where the newest, most promising therapies are being tested. If a trial isn't an option, the choice of therapy often depends on how long the first treatment worked, what we call chemosensitivity.
Okay, how does that work?
Basically, if a patient's cancer progressed relatively late, say more than 90 days after finishing their last platinum-based chemo, they're considered chemosensitive. In these cases, retreating with platinum adiapocyte again can sometimes be effective and improve progression-free survival.
And if it comes back sooner than 90 days?
Then they're considered chemoresistant or refractory. For these patients, repeating the same chemo is less likely to work. Here, an FDA-approved option is a drug called lurbinectedin.
Lurbinectedin? How does that work?
It's a type of drug that damages the cancer cell's DNA, an alkylating agent. Its overall response rate is around 35%. But interestingly, it works better in patients who had a longer chemo-free period before starting it. If that period was over 180 days, the response rate jumped to 60% in the trials.
35%. Still seems modest. Are there newer things coming along? I think you mentioned tarlatamab.
Yes, tarlatamab is really exciting. It just received accelerated FDA approval. It's a totally different approach, a bispecific T-cell engager, or BiTE.
A BiTE. How does that work?
Think of it like a molecular matchmaker. It has 2 arms. One arm grabs onto a protein called DLL3, which is found on the surface of most SCLC cells, but not many normal cells.
Okay.
The other arm grabs onto T cells, the patient's own immune killer cells. So tarlatamab physically brings the T cells right next to the cancer cells, activating them to attack and kill the tumor.
Wow, like a guided missile for the immune system. How well does it work?
The results that led to approval were quite promising for this difficult-to-treat population. The overall response rate was 40% at the approved dose. And importantly, for those who responded, the responses seemed quite durable. 59% lasted 6 months or longer.
40% response in chemo-resistant relapse. That sounds pretty good.
It is definitely a step forward, offering a new option with a novel mechanism.
Any major side effects with tarlatamab?
The main one to watch for is cytokine release syndrome, or CRS. That's an inflammatory reaction that can happen when the immune system gets activated strongly. It causes things like fever, low blood pressure, but doctors are getting much better at managing CRS. It's usually treatable.
Okay, so we've covered systemic treatments. What about managing specific complications? Brain vets seem like a big one.
Absolutely. If brain metastases are found at diagnosis in someone with extensive stage disease, but they aren't causing symptoms, the initial chemoimmunotherapy might actually treat them too, as some of these drugs can cross into the brain.
But what if they are causing symptoms? Headaches, weakness?
Then it's an urgent situation. You need immediate treatment before starting systemic therapy. That usually involves high-dose steroids, like dexamethasone, to reduce swelling, plus radiation to the brain.
What kind of radiation?
It depends. It could be whole brain radiation therapy, WBRT, or increasingly, if there are a limited number of spots, say 10 or fewer, stereotactic radiosurgery, SRS, is preferred.
SRS, that's the very focused kind.
Exactly. Gamma knife or similar technologies. The big advantage of SRS over WBRT is a lower risk of causing that long-term cognitive decline we talked about with PCI. So if possible, SRS is generally favored these days for treating new or progressing brain mets.
Makes sense. What about managing those other things, like the SVC syndrome or the paraneoplastic syndromes?
Right. For SVC, the primary treatment is usually chemotherapy to shrink the tumor causing the blockage. But if chemo needs to be delayed, steroids or emergency radiation can provide rapid relief. For the paraneoplastic syndromes, it's about treating the underlying mechanism. For Cushing's, drugs like ketoconazole can block hormone production. For SIADH, might be restricting fluids, salt tablets, or specific drugs. For Lambert-Eaton, treatments like IV immunoglobulin can help the immune system.
And radiation for other symptoms.
Yes, palliative radiation is incredibly useful for localized problems, like if the tumor is blocking an airway, causing significant bleeding, hemoptysis, or if there's a painful bone metastasis. It can provide excellent symptom relief. We also need to manage treatment side effects. Chemotherapy often causes myelosuppression, low blood counts.
Anemia, low white cells, low platelets.
Yeah, exactly. Low white cells, neutropenia, increases infection risk. This is often managed preventatively with growth factors, GCSF injections. But there's also a newer drug, trilaciclib.
Trilaciclib, what does that do?
It's a CDK4/6 inhibitor that's given before chemotherapy. It sort of temporarily pauses the bone marrow cells, making them less susceptible to chemo damage. It's been shown to significantly reduce the severity of low counts and the need for interventions like transfusions or growth factors.
Interesting. Protecting the marrow. What about tumor lysis syndrome?
That's when tumor cells die off really quickly with treatment, releasing their contents into the blood, which can overwhelm the kidneys and affect electrolytes. It's not as common in SCLC as in some leukemias, but we monitor electrolytes and kidney function closely, especially early on. Sometimes medication like allopurinol is given beforehand to prevent it.
Okay. One last but crucial area, palliative care. Why is it so strongly recommended for all SCLC patients right from the start?
It's absolutely vital. Palliative care isn't just end-of-life care. It's specialized medical care, focused on relieving symptoms, pain, and stress of a serious illness, whatever the prognosis.
So improving quality of life.
Precisely. And the evidence is compelling. Studies show that integrating palliative care early for patients with advanced lung cancer, including SCLC, leads to better symptom control, improved quality of life scores, physical, emotional, social well-being. And here's the really striking part. It's also associated with longer survival. One key study showed patients getting early palliative care lived nearly 3 months longer, on average 11.6 months versus 8.9 months.
Wow. Better quality of life and longer survival.
Exactly. It shows that addressing the whole person, managing symptoms effectively, supporting them emotionally, it actually impacts the course of the disease. It also facilitates crucial conversations about goals of care, ensuring treatment aligns with what matters most to the patient throughout their journey.
Okay, we have covered a lot today on small cell lung cancer. It's clear it's a very aggressive disease. That strong link to smoking is undeniable, and the fact it often presents late is a huge hurdle. But we've also seen some really remarkable progress, especially in limited stage, that consolidation immunotherapy is a massive step forward for survival.
Definitely.
And even in the relapse setting, these newer agents like parlotamab, using totally different mechanisms, they offer real new hope.
Absolutely. It really emphasizes this multi-pronged approach, doesn't it? You need the systemic treatments, yes,
Yeah.
but also aggressive management of symptoms and complications, and that early integrated palliative care. It's that comprehensive strategy that seems vital for improving not just how long patients live, but how well they live.
Well, we hope this deep dive gave you that shortcut, helped make sense of a really complex topic, maybe highlighted some surprising things along the way. So what does this all mean for you listening in?
Well, here's something to think about. Given how quickly SCLC evolves, how smart it is at resisting treatment, what are the next breakthroughs we need? Where should research focus to really understand the deep biology of why it becomes resistant so we can finally develop truly personalized, lasting cures for more people?